Tony Ng from King's College London. It's a real privilege to introduce Professor Tom Treasure, and he's a consultant cardiothoracic surgeon at the Middlesex at University College Hospital since the 80s. Nowadays, he's an honorary professor in the Clinical Operational Research Unit in UCL. Professor Treasure is a real expert on randomized controlled trial. He's been elected to the Council of Royal College of Surgeons, and he was the president of the European Association of Cardiothoracic Surgery. I think we are in for a real treat. He's going to summarize his thoughts about, in terms of surgical procedure, what new treatment can replace the old ones, and when we should stop the treatment that are no longer appropriate. So, Tom, the forum's yours.
Thank you very much for such a kind introduction, Tony. So now I need to share my screen with you, and we're going to, I'm doing this cautiously to avoid mistakes. There we are. So there's my title, Striving for Evidence with and Without an RCT. Like others in this series, I'm very complimented by being introduced as a giant. I'm grateful for it. But as I go along, I will introduce you to some of the people some of the giants whose shoulders I stand on. And as I go along, I'll introduce you to them. The first giant I'm going to mention is Russell Brock, who introduced heart surgery at Guy's Hospital in 1948. This book is about that episode. There were two endemic heart diseases with very large numbers of patients suffering from them: rheumatic mitral stenosis and cyanotic heart disease. They were both due to narrowed valves predominantly, and were completely untreatable. And the mitral stenosis patients were poorly from their teenage years and had a progressive disability and died young. Few of the blue babies got out of school age, got into school age. But what was interesting was that there had built up a very, very firm resistance against any question of heart surgery. So the Russell Brock overcoming that was a very great achievement. So that was in 1948. Now, a giant of, now I've got a caption, let me see if I can close it. It's obliterating some of my, yes, I've got rid of it. A giant of critical thinking was Daniel Samways. This is his biography. And in 1898, he wrote to the Lancet an article anticipating surgical relief of mitral stenosis. And it was 50 years before it was accepted. So some of these things take a long time. The take-home message for those who are willing and able to accept the challenge is, if you see, hear, read, or are taught something that doesn't look right, question it, check the evidence behind it, and if it's inadequate, put it to the test. Now, not everybody can do that or wants to do that. And if we all go around questioning and challenging, we not get much work done. But if the opportunity comes along and you think it is something that should be questioned, you should do so. And the others of us should listen. Muir Gray opens this book with a vignette about resection of colorectal metastases in the liver. Note the first line of page 1. I urge you to read it. You'll see why. But more important for the moment is this little 2x2 matrix in which he classifies treatments as either high value or low value, and provided or not provided. So in 1948, heart surgery was not provided, and Brock got it going. What I'm going to talk about first, though, is lung metastasectomy, which is provided, but I am going to argue that it is of low value, and I'm going to ask, should it be stopped? So I was a consultant in the Middlesex Hospital with my first appointment when I was quite young, doing a mixture of cardiac and thoracic surgery. And next door, the pure thoracic surgeon was removing metastases from the lung. I have to say, at the time, it didn't look right to me. Didn't seem plausible. And most important, running throughout the first part of the talk, there were no control data. So in 2019, the Society of Thoracic Surgeons, in their journal, the Annals of Thoracic Surgery, published an expert consensus document on pulmonary metastasectomy. In the preamble, they wrote that there had been more than 1,000 publications on the subject, no randomized trials, but metastatic disease survival is assumed to be 0. Survival gain is believed to be 40%. Now, despite those caveats, there followed 8 pages of recommendations. But what about the pulmonary trial? Well, in 2017, I'd been in correspondence with the leader of the consensus document, consensus process. It was a Delphi type process. And indeed, in the paper that was published, he explained a fair amount about the pulmonary trial, but he didn't get back to me for any results. By this time, the results were actually in the Annals office in September 2019, at the very same time as that they were publishing this. Well, what might they have learned if they bothered to ask? That's the randomized trial in 93 patients, and you can see that the 2 lines weave in and out of each other. They don't separate to any extent, and there's certainly the confidence overlap completely. So this contradicted 3 things explicitly in the expert consensus. An RCT was available, control survival was not 0, and survival gain was not 40%. The trial was nested in a cohort study of a total of 512 recruited patients, consented, and the data collected to trial quality. Most of this going through Graves unit. And I should mention that that my co-chief investigator was Leslie Fallowfield, who's up in the next meeting. I've mentioned the 93 randomized patients. There were 391 going through the same process, in whom the MDT with the patients made the decision, and the majority had a lung metastasectomy. And these are the outcomes. So in this upper line, there are the 263 who had an elective metastasectomy. The overall survival replicates the best reported observational studies, so I would argue that this indicates face validity of the cohort study and the nested randomized control trial. 128 did not have a metastasectomy, and that's the survival for them. So they were good enough to be considered, but then turned down, and this robustly refutes the 0% assumption. Now, of the patients selected to have metastasectomy, many more had solitary metastases, about twice as many. Fewer had carcinoma embryonic antigen with a tumor marker, and that's about half of the elevation of it, that's about half of them. Fewer had liver metastases. The average FEV1 was 10% higher. Those free from any impairment were in the majority, and about twice as many, and they were on average 5 years younger. The arms were balanced in randomized patients for all the items which we collected, which are the many known factors that influence survival. So age and sex, the primary cancer stage, the interval since primary section, the liver involvement, number of metastases, the tumor marker, the lung function, and ECOG performance. And when they were balanced, there was no survival. Now, these are things learned along the way. I'm pausing because I am just moving this thing from its rather awkward position over there. One of the things we learned along the way is patients are not the major obstacle to randomization. It is clinicians' belief. We were pressed by the data monitoring committee to explain why recruitment was poor, and the 3 highest recruiting teams provided information on all of their 155 patients on why they had not been randomized. 41 patients elected to make their own decision. 22 chose metastasectomy and 19 chose to not have a metastasectomy, about even, suggesting that the patients who were fully informed understood equipoise. The clinical teams, on the other hand, overrode the trial protocol in 78 patients, and 77 went for metastasectomy. That's 99%. And then other classifications thereon. That's the main message. Patients are not, in this study, the obstacle to randomization. It's the doctor and their teams. Now, this is something else that we learned along the way. This is an analysis of 220 patients in the non-randomized group in centres who were collecting richer and better data. Now, we have to remember that in a trial such as this, the thoracic units will do the metastasectomy, but many of those patients go elsewhere or return back for follow-up. Good track is difficult to keep, so these ones were particularly good at it. And what you see here are stacked lifeline plots. So each line represents a patient's lifetime, and they're stacked according to their survival. So you can see this contour approximates to a Kaplan-Meier, another survival plot. It's derived in a different way, but it looks rather similar. I'll show you about that in a minute. These 51 had no metastasectomy, and blue indicates a patient free from metastasectomy. This group of 114 had one metastasectomy after varying interviews in the process before having it. And now look at the shape of this contour. It's very different. And that's guaranteed time bias. How it comes about is that these patients have been identified sometime prior as potential candidates. And this is from the time of consent and entry into the trial. During that time, they may have had chemotherapy in some units, they've been thought about, they've been re-imaged, and their progress is watched. And by the time they are then have the metastasectomy, they have declared their intention to stay alive for a while, and very often 1 to 2 years. You see that in randomized control trials, but because of the nature of the study, it exists in both arms, so you can ignore it. But here, it provides quite a substantial impression of benefit for this comparator. Then down the bottom are 55 patients who had more than one, anything up to 5 local interventions, either metastasectomy or ablations or saber. Now, the usual perception in these observational studies is that further treatments result in longer survival. But the association may be reverse causation. Patients who are surviving longer provide opportunities for people to do things. So without association is not a causation, as you well know. And this bulge has been seen before. These are data of thousands of patients having liver resection for colorectal cancer. And it was published in the BJS. And I point out to you, this bulge here is the same sort of thing as you see there, and for the same reason. These are typical cancer survival plots, and they're timed in registries. They're timed from the time the patient's put on the list. And there's usually a bit of a steep fall, and then it levels off. None of that happens to these patients who have got guaranteed time bias. Another giant, Martin Utley, who is the director of the Clinical Operational Research Unit for the years that I was associated with it, not just in retirement working. It's terribly simple, nothing sophisticated, but that's one of the clever things about people who can understand about Schrödinger's cat. He's a particle physicist up to his PhD. Now counts numbers for the NHS. So here are patients sorted according to notional, this is a theoretical, increasing intervals since primary resection, which is a favorable factor for outcome, and the number of metastases, which again, the fewer, the better in terms of survival. Of 300 patients, 25 in this model are selected for operation, and 10 out of 25 are 5-year survivors, and there you get your 40%. What you do not know in any of these observational studies, and there are 1,000 of them, is anything about this lot, how they compare with them, and what would have been their fate, and what would have been these people's fate if they were not operated. In fact, in NHS data published just last year on 175,000 patients, it's about 1 patient in 50 gets a metastasectomy after colorectal cancer, lung metastasectomy. So you may wonder, what's there to worry about? Well, let's get things right. Now, this is a naive assumption that underpins all of these studies. So here is a 5-year survival estimate of about 40% with its confidence intervals, and it's notionally imaged against stage 4 cancer survival. Now, that's erroneous because these patients at the time of registration, even though here they may be dying of metastases, at the time of registration were in all the stages, and with survivals up to about 75% for the very best of them. So what Martin did was to ask us to supply some published case series. Now here, these patients in this Japanese series had a median interval between their primary operation and their metastasectomy of 2 years. Now there's a thing called the DFI, disease-free interval. Well, that's clearly false. These patients are not free of disease if they come to metastasectomy. It's just you haven't seen them yet. But he called it the death-free interval. Now, patients who have died before reaching this interval should not be included in the model. So you take them out. And then the conditional survival model corrects the stage mix, and so he plots this line, which actually is rather similar to the observed 5-year survival rate. And just to check it out, did it again, and these data from Memorial Sloan Kettering. The interval here is about 3 years, which is quite typical. And again, you get the same result. While all this was going on, we were interested in collecting information in parallel. And I knew that at the same time as I was a young consultant in cardiothoracic surgery, a friend of mine was running the CEA second look trial. So what they did was, this was early on in the days of CEA, and there was a practice of what was called second look laparotomy. So that was without evidence of recurrence. Some enthusiasts were bringing their patients in, reopening the belly and looking around for local recurrence, lymph nodes, and indeed liver recurrence. That was beginning at the time. Now, I wanted to get hold of the study, and it was never properly published. It was in JAMA as a letter. And I asked the chief investigator, and he said, "Oh, it was terrible. We had to abandon it." So I went to see if I could recover the data. Well, I went to the chief of the trials office, and he said, "Look, you've got no money to go through all that again." I said, "Well, it's a change of emails. I don't want any money. Retire myself, and we can do this on our own time." Actually, the data are corrupt. And I said, who says that? And finally, he said, "Well, you can't get them anyway because they're off-site." Well, it happened that there was a lady researcher who had worked with them, who was part of that trial. And she said, "I think the data might be still there." And she was involved in Ulmich. So along with Chris Russell, who was a senior general surgeon at Middlesex, we got our hands on the data. In fact, as I'm illustrating here, they were in the office, in a cupboard, all there. In fact, there were also perfectly interpretable records on disks and electronically saved on 1,447 patients. And working on that with a couple of helpers who had skills I didn't have, we recovered data on 1,446, which was reliable, went to death registration and completed got complete decertification of all of these patients. The green ones, who, as you can see, have about 60% 5-year survival, did not have an elevation of CEA. These all had an elevation of CEA, and according to the protocol at the time, they were randomized, 2 groups, to either have that revealed to the team, who could then act on notification and do further surgery, or not. And as you can see, not a bit of difference. And that's long follow-up and carefully collected data. There have been altogether 2 meta-analyses of 16 RCTs of surveillance strategies, becoming more intense and altered intervals, new tests going in. Metastases are consistently detected nearly a year sooner, and there are more metastasectomy operations, but a survival benefit has never been shown in any of these studies, or does it emerge in the meta-analysis? If anything, there's a slight detriment. Well, taking the long view, surgery in the time of Samways included the Halsted mastectomy. This series was 1889 to 1894, and that remained as the standard with increasing degrees of invasiveness until Veronesi's randomized trial. So that persisted for 90 years. So and the lung metastasectomy has only been going for 40, so you've got a bit of a way to go yet, perhaps. Well, now, to get away from all that apparent negativity, in fact, the trial gives hope, I would say, to some patients who can be spared an operation which isn't going to be of value to them. But now I'm going to look at something which is more elevating, if you like. Introducing a better operation for Marfan aneurysm, which is of potentially high value, but at the time was not provided. So here's another giant, 6'6" Marfan, and he was offered, but did not want a mechanical heart valve. He did not like the idea of being on anticoagulants, which gives the risk of bleeding in addition to the risk of thromboembolism. And they have these, anybody with a mechanical valve in is at risk. And every year of 100 patients, there's 2 or 3 will get one and 2 or 3 will get the other. They may recover or not, but it's a pretty bleak future as far as tau was concerned. So I was giving the lecture at the Marfan Association in 2000, and up stood at the end, Tao, looking me straight in the eye, saying, "Why don't you surgeons get up to date and use CAD modeling and RP?" Well, I had to admit, I was stumped. I didn't know what those things meant. So I said, well, look, let me take a few questions that I might be able to answer. Let's find each other over coffee. So we did. And this is what transpired. This is on the left is his X-ray in 2000, right? So this was 2000. So it's an MRI. There's the aortic root, there's the valve and the arch, and this is way bigger than it should be. And of these patients with Marfan syndrome, 70% die of this single cause, dissection and rupture of the aorta, and often at young age. He got to his 40s, so he was at the lucky end of the spectrum, but 20 or 30%, ages 20 to 30 is quite common. So the CAD modeling he was talking about is computer-aided design, based on these images. From that, RP is rapid prototyping, or what we would call now 2D printing, to make a replica of his aorta. And then on that, fashion this mesh, which is made of the same material as cardiac grafts, so well tried and tested, but is soft, pliable, and has a pore size of about 0.6 of a millimeter. So microscopic structures, fibroblasts can go into it, and it becomes completely incorporated. You want to find a surgeon skilled with nerves of steel and patience. The first of these operations were done by John Pepper at Brompton, because at that point, I'd moved guys to not do cardiac, but just thoracic. It's positioned there, and getting down below the coronary, right down, excluding all of the aorta is important, and that's his aorta 18 years later. unchanged, I might say. So now look at when you don't need an RCT. If the problem can be solved by an operation which is completely explicable mechanically, hip replacement, cataract, mitral stenosis, synostochondrosis, and the patient gets much better, remains better, is reproducible, and with a large effect size, you simply, the innovation itself and the proof that it works is enough. The same was true for root replacement for Marfan aneurysm, which was first done in 1968 and was my standard care for these patients through the 80s and into the 90s. Now, there are also obstacles. So they don't need an RCT, but there are obstacles to an RCT, even with the best of intentions. And we went to the highest court in the land on the subject, which was the NCRI's NIHR, the Research Institute's Trials Design Service. And working with them together, it became clear that there were two decision nodes at which you might consider randomizing, but neither of them was the equipoise. One was the timing of the intervention. With this non-ablative operation, which had much less perioperative risk, well, yet substantially less perioperative risk, and avoided the risk of anticoagulation thrombosis, there was possible to move in much earlier in the evolution of disease and get much better results and spare the patient the waiting and anxiety. On the other hand, patients would have to wait until they really sort of earned their operation, get a root replacement. So there was not equipoise there. There was also a matter of patients' fully informed preference. A young woman wanting to have children might choose to have a tissue valve, even if there was a necessity for an operation in 15 to 20 years' time, whereas other people might want the security of the Rolls-Royce operation, which is the perception of mechanical heart. So not doing a randomized trial for it, it more or less fell into place to use the IDEAL framework, which is an acronym for the idea, its development, its exploration, assessment, and long-term study. I was involved in that at its outset. It was published in The Lancet in 3 substantial papers in 2009 and revisited in 2013. So looking at Tyle's operation through that framework, the 2000 was the proposal, and 2004 was the first in man, and during that time we had first-class collaboration with star quality cardiac anatomy, imaging, computing bioengineering to refine it. And Tile then was the first in man in 2004. We did a really very neat, and I say we, it was led by Martin Utley, and we had a vascular radiologist looking meticulously at a blinded imaging study of multiple images to show efficacy. And in all cases, the aorta did not get bigger, and in some was actually constrained, then that's a benefit, by the operation. As time went by, as patients improved, we did a matching study to check that our perception of short-term gains, less transfusion, shorter hospital stay, and avoidance of bypass were achieved, which they were, and then study reverse events. We're now into the long-term study, the first 200 published as a clinical series, but also just doing some big data analysis with a thing called the Aviator database and meta-analysis and microsimulation. So defeated in my attempts to do it with a randomized trial for good reasons, we then went to this, which is not too bad second best. So in 2022, we're approaching 700 operations by 31 teams in 12 countries. And you can see the first years were very slow and people not wanting to change to this new practice. And now these are the countries that are carrying it. You will note the United States is missing. They have throughout advised, as the patient's advisory system, the American Marfan Association, that this is not an operation they should have. Meanwhile, of course, they're doing the operations which they've done over the years and are course, very well paid for doing it. And I can understand their reluctance, because if you spend 2 decades of your life, as I did, through the 80s and 90s, getting better at the standard operations, you'd be reluctant to part with it. And of course, all your biases would be against it. But that's the story of that one. So, say again, if you see something that doesn't look right, question it, check the evidence behind it, and if the evidence is inadequate, put it to the test. This is the ability to do this is the Scout mindset. Nice book by Julia Gallo, who explains why, of course, we do tend to stick with the majority view. We tend to take the safe play, and not everybody and not all the time has this Scout mindset, but Tal did. So good for him. So there's 2 very different experiences over quite a long time of trying to find the answer to what seemed to me the metastasectomy to be a problem, and what was a problem to Tal.